The aim of this talk is to look at MRI and how it can characterize vessel wall disease. As we've heard from Jean-Claude, we're looking for signatures within these images, MRI specifically, as biomarkers of end organ disease, looking at the local cause of a distal effect, trying to detect that local disruption and the end organ effect at the same time. And Kane, looking at hearts and minds, obviously is looking at heart attack and stroke. And for me, these conditions are very similar, certainly the primary disease. So a theme that you will have noticed already is that is at the basis of the heart of Kane, is that we're looking at the primary supplying blood vessel and the end organ. The blood vessel itself, you can have a direct flow effect on the end organ where you have narrowing and total occlusion, coronary thrombosis being a good example. An indirect effect where you're having emboli going to the end organ where there's plaque disruption. Again, these primary events in the vessel are the same, having a secondary effect on the end organ. Okay. So what opportunities do we have with imaging, and again with MRI specifically, to detect different areas that we could use as biomarkers? As Ben was showing, we can look at the culprit lesions themselves, geographic type techniques, looking for stenoses and occlusions, as we see in this carotid artery. Looking for future culprit lesions. This is trying to be a mediocre doctor, which I strive to be. Looking at carotids, this is an axial image through the carotid vessels. The image on, I'm a radiologist, I never know whether it's left or right. So the far side is showing an area of high signal intensity, potentially a marker of disease going on within the carotid artery. Patient otherwise asymptomatic, and again very similar to Ben's images, the lumen completely maintained as opposed to the normal carotid on the near side with no high signal. So if we can generate images that have characteristics that are going to predict disease in the future, these may well be useful biomarkers. And finally, using MRI as a measuring tool, an expensive one, but an accurate one, whereby we can image a patient at time point 1 on the top images, ask them to come back a year later, use MRI to measure volumes, lumen areas, etc. This work by Chunyuan in Washington showed nicely that MRI is a very good tool at measuring progression of atherosclerotic disease in the carotid. And finally, looking at total patient risk, as I was alluding to, vascular disease is a systemic one, and so what goes on in the carotids can often be assumed to be going on systemically within the body. This was an interesting paper looking at patients who had had endarterectomy. They had had a piece of their carotid taken out and looked at histologically. And this group looked at the characteristics of that endarterectomy specimen. In this case, they were looking at plaque hemorrhage, and then they just followed the patient and looked for death and vascular events. And those patients that had plaque hemorrhage is the red line, where you can see their events was far higher than the blue, where patients didn't have plaque hemorrhage. In other words, this was a snapshot using histology to phenotype the patient, and then assume that process was in some way marking the patient for future events. So again, MRI may have that same capability. So carotid disease, the brain is a useful example, and again, we may get there in the heart sometime soon of a comprehensive vascular imaging technologies. We can perform luminology, in other words, angiography using MR, and we can look at the vessel wall itself. Obviously, in the neuro setting, we'll be looking at stroke and ischemic events, but hopefully in the cardiac setting, in a few years' time, we'll be looking at coronary events as well. What are we trying to do with MRI? What can we achieve? We can look at brain, aorta, peripheral vasculature. These things are all possible. Coronary arteries are possible at the moment, but probably not to the degree that we would use them in trials. The end organ imaging, however, is ready for prime time without doubt. For those of you that use MRI, there's the holy sort of triumvirate of confounding factors. You either have time constraints, spatial constraints, or the amount of signal that you can generate from the MRI image. Temporal, you can scan longer to get more information, but there's a question of patient comfort, whether they start to move around, and also even just the physiological movement from pulsatility and respiration. Spatial resolution, you would like to look at a large field of view with high resolution, but that takes longer. Signal, you would always like to have more signal, but that takes longer, and therefore all of these things, you can't have all three of those things at the same time. What we can aim our MRI scanner at looking at is the lumen, looking for vessel narrowing and stenosis. This is something we've been used to for the last 20 years with all of our techniques in medical imaging angiography. With MR, it's non-invasive, it's repeatable, and certainly gives you a snapshot of the current situation of the patient, of their stenosis and risk. Vessel wall imaging is relatively newer technology. It is actually looking at the vascular disease itself, the true disease, not just the effect it's having on the lumen. And again, as Ben nicely showed, it's looking at hidden disease, the actual way that the vessel responds to disease is commonly it will grow outwards rather than inwards, and therefore the lumen is not a good marker of vascular disease until it's almost too late. So we need to be looking at the vessel wall itself, and we need to be characterizing the vessel wall to see if that will tell us which patients will be having future events. So this is the coverage that we can achieve with MRI. We can go from the bottom of the picture in the aortic arch all the way up to the brain vasculature, looking at the circle of Willis. We have a very good coverage with MR. We can look at both sides at the same time. And this just happens to be showing that you don't really need much contrast to get these images. Whether you use 10 mils of gadolinium or 5 mils, we get exquisitely detailed pictures. Because it's a three-dimensional technique, we can reconstruct these pictures to look at specific areas. If we're more interested in the cerebral circulation rather than the carotid circulation, this is all coming off one, I think it's about a 50-second acquisition. Then, because the patient's already in the scanner, we can add into that the end organ imaging at the same time, in this case the brain. So because it's a three-dimensional technique, we're not restricted by having to take one view one at a time and hoping that we're going to get the lesion that we want to see. We can take that three-dimensional data, post-process it, rotate it, look for the lesion that we're looking for. And again, we have the ability to add in the end organ and superimpose upon that the vasculature supplying the end organ to sufficient detail that if we can then hone down on certain areas, in this case we can see a small outpouching from that left middle cerebral artery, which is a small aneurysm incidentally picked up during this trial. Moving to the vessel wall itself, again, not only has the imaging moved on in the last 20 years, but our understanding of the actual pathological process within the vessel wall and atherosclerosis has also moved on from one where we thought of vessels as pipes that became hardened to now thinking of the vessel wall themselves as an intricate pathological process. The atherosclerosis going on within that vessel wall is more akin to a small microtumor rather than just a furring up of a pipe. The vessel wall has its own blood supply. This blood supply becomes stimulated when there is atherosclerosis, and the blood supply then grows into the vessel wall. That introduces and allows in various T cells, mast cells, macrophages. These vessels are leaky. They leak cholesterol, and eventually not only are they leaky, but they are highly fragile and they can bleed. So within that excuse me, milieu, you end up with collection of lipid core, hemorrhage, inflammatory tissue, which after a while becomes a cyclical process, one feeding into the other and driving the process of atherosclerosis. What does that leave us to image with regard to atherosclerosis? Well, we can look at the stenosis itself, as I've said, the residual lumen. We can look at the volume of plaque because of our 3D techniques. We can look at the volume of lipid within the vessel wall, markers of inflammation, and markers of hemorrhage within the vessel wall. And so just as on histology, we can pick out certain specific characteristics, whether it's inflammation, microvessels, or hemorrhage. So we can use MRI because of its exquisite characterization abilities. Using different weightings of images, we can hopefully characterize the images themselves. I won't go into the technical details, but we image the carotid with the MR with different weightings that give us different signal intensities, which we can then interpret and correlate with, and has been done with histology to tell us what the characteristics are within the vessel wall itself. I put here high resolution at 0.5 millimeter in plane. To some people that's high resolution, to some people low, but from a clinical point of view, it's certainly pretty high resolution with regard to vessel wall disease. We tend to suppress the flow of the vessel itself. This just tends to give us better pictures. Fat in a lot of these images overrides the amount of signal, so we try and take that out as well. The targets that we can look at, as I've just said, plaque volume, lipid core, fibrous cap, near vessels, hemorrhage, and calcium. So getting down to the nitty-gritty, these are the types of images that we can acquire. We tend to get about 6 different weightings at each individual slice of both carotids, so there's a lot of information just to orientate the non-images. At the top of the picture is the chin, at the bottom of the picture is the back of the head, right and left. In the middle of the image, the actual black circle are the carotids. As we sort of hone in on that, we can see that in a bit more detail, and I'll go even further. So this is the type of detail we're getting on each carotid at each level. So these are 2 millimeter slices with different weightings. On the far image, the TOF, the time of flight angiogram, the lumen appears bright because we want it to appear bright. On the image below that, IPH, intraplaque hemorrhage, sequence designed to really enhance the intraplaque hemorrhage signal. Hemorrhage within the vessel wall appears bright. But you can see between each of those weightings, we're getting different information represented in the image as different signal intensities. So now we can move on and not only look at the lumen from aortic arch to circular Willis. And so in this patient who's got bilateral stenoses, you can see as you travel up on the near image, there's a very thin internal carotid with a bit missing, which is not a complete occlusion, but shows there's a very tight stenosis. And on the other side, a similar appearance. And now we want to know what's actually causing that disease. And on the cross-sectional image through those carotids, looking at the left-hand carotid, you can see that high signal within the vessel wall representing hemorrhage. On the right-hand side, we just have a rather bland image which suggests there is no hemorrhage. So we're starting to pull out risk factors within each of those stenoses. Similarly, this patient with again, very similar picture to one that Ben showed, just with a small bite taken out of that proximal carotid artery. They're having problems in their head bilaterally. They have high signal intensity in their deep white matter, suggesting ischemic disease. Their actual circular Willis doesn't look too bad, so it's probably disease coming more proximally. And then when we look at their carotid arteries, we can see high signal intensity within both of their internal carotid arteries, marking out that they have active disease going on within their carotid plaque bilaterally, whereas the stenosis would only suggest that it's on the one side. This patient is running on empty. Without going into too much detail, their left carotid is completely occluded. If you look on the second image, they have a pinhole left of their right internal carotid artery. They have a stenosis in their distal left vertebral artery, so they're now just running on one vertebral artery, which is not a clever thing to do. We can look at their brain, which is in fact not too badly off, but if we look on a different sequence, we actually see significant high signal intensity, which is again ischemic damage already occurring. And despite their carotid problems, thanks to the wonders of nature, the circular Willis having so much redundancy, enough blood is getting from one side of the brain to the other to actually maintain most of the brain function. And so we get to the CANE project, which Jean-Claude mentioned, and this is really the imaging sequences that we use, that we can look at the whole of the carotid circulation with a contrast-enhanced technology. We can use time of flight, which is non-enhanced, to get high-resolution images of the carotids. And then we can start to look at the vessel wall lumen itself, which in this case on the luminogram, on the angiogram, looks relatively normal. But as you can see at the same level, we already have significant disease within the vessel wall. And then we can start using our different sequences to pull out different information at that same level, whether it's looking at inflammatory change or intraplaque hemorrhage, near vessels, at each slice through the carotid artery. The CANE project, CANE Project 1, which is mainly looking at natural history of atherosclerosis, is using the carotid bed as its test bed. We're looking to recruit 540 carotid patients, some symptomatic, some asymptomatic. And the sites that are recruiting for us are using 3 Tesla MRI scanning, multi-parametric sequences, which I've just shown you, and then we're imaging at time point 0, 1 year, and 2 years. And the idea is that we know already that there are single center studies out there that have shown there are various characteristics within the carotids that will allow you to dichotomize patients into high risk and low risk. And we're now wanting to take that out into a multi-center setting to see if this can then truly be translated into the clinic. The images on the far left again illustrate that a patient with a normal looking carotid circulation is still starting to have brain lesions in that left hemisphere. And if we then start to look at the vessel wall itself, we can see areas of high signal intensity within the vessel wall, but not compromising the lumen, which are likely accounting for the brain lesions. And these are exactly the type of things we want to try and pick up with the CANE trial. We'll be looking at patients' outcomes from a clinical perspective, stroke and death, and hopefully refer back to their original imaging to look for the biomarkers that would have predicted those future events. And also we want to use the imaging as a natural history trial to better understand atherosclerotic evolution over time. And each of these patients we'll be looking at plaque volume, various constituents of their plaque, and see which of those is actually influencing plaque progression. Jean-Claude was mentioning that the techniques that we use have to be reproducible, and we believe that whether it's 2D measurements or 3D measurements, we have good reproducibility with MRI. And we can see already as the patients are coming back for their 1 year and 2 year follow-ups, similar to that paper by Yuan from Washington, we can get very good reproducibility of all the different sequence parameters, both at time point 0, which is the top line, and then when we follow up the patients 1 year later. From that, we're already starting to post-process that data, and the lighter line at the bottom is the patient's first visit, looking at their plaque volume, slice by slice through their carotid. The dark line above that is their 1 year follow-up, and you can already see in various positions within the carotid, there has been progression of the volume of disease at those sites. Recruitment for CANE, slow start, as with any multi-center study such as this. We're now getting into our stride, and with probably another 4 sites on top of the 7 already who are recruiting for us, will further increase our recruitment rate. And just to finish up, some future developments. Again, Jean-Claude mentioned that dealing with all of this data is a problem. We have to deal with it reproducibly and in a timely manner. I've already shown that these patients coming in are having a huge amount of data. They may have 6 sequences, both carotids, on multiple occasions, and we need to keep up with data processing. Improving tissue characterization as well. We have the technology there to look at different signal intensities. We can actually make measurements within the vessel wall itself to improve characterization in that sense. At the present time, we're working on various post-processing technologies that will allow us to take the raw data as it's all three-dimensional. We can play with that data and straighten out the carotids, because the tortuosity of the carotids often makes it difficult for us to post-process. And the red line represents the lumen, the green line the outer wall, and the blue line is basically vessel volume all the way along the carotid from the arch to the circular Willis. And so when we dice and slice that, we have a very ready means of actually getting the volume measurements off that, which can be superimposed back onto the images. Whether that's a simple non-stenotic vessel or more stenotic vessel such as this, we can then again straighten the vessel, look where the high signal is indicating vessel wall disease, and then deal with the whole of the post-processing on a three-dimensional data set. Looking at better characterization, T1 measurements is a fundamental property of the tissue itself that we can measure. And if we can then, instead of relying on visual interpretation of MR images, we can start to look at T1 measurements. We have a better way of quantifying the tissue characterization. And part of CANE 2, which we'll probably hear more of later on, is using endarterectomy specimens, histology specimens, to correlate disease that we see within the images with those that we see in the histology to further improve our technologies. And with that, time is getting on. Thank you very much.